Thank you for joining us. The webinar will begin shortly. Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Spring 2024 Weather Report. It's Raining Rules. PYA is happy to present today's webinar on this important topic. Before we get started with the webinar, I'd like to go over a few housekeeping items. As this event is for 1.5 CPE credit hours, there are some additional steps that we will take in order to comply with NASBA's requests. Attendees will be provided 5 polling questions throughout today's webinar. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time to receive CPE credit for this course. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and post-event survey must be submitted for proof of participation today. You may submit questions during the webinar by typing a question into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to these questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thanks, Trevor. Good morning, and thank you for joining us. Oops. I knew I'd do it, Kathy, right away. There we are. Thanks for joining us. We're going to do 90 minutes today as opposed to the usual 60 minutes for HCRR webinars because, as they say, when it rains, it pours. And since the end of March, the federal agencies have been pouring out a number of proposed and final rules for us to review. We're going to cover 12 rules in 90 minutes, plus 5 attendance questions. So that puts us at about 7 minutes per rule, but of course will vary. Kathy Reep will take rules 1 through 5, which are the proposed rules for federal fiscal year 2025. She will highlight key provisions and also make suggestions regarding comments that you may wish to submit to CMS on those proposed rules. I will take 7 through 12, which are the final rules that have been issued since the end of March, really more for awareness as opposed to helping you develop a specific implementation plan.
Martie.
Yes,
if I'm doing 1 through 5 and you're doing 7
I'm doing 6 through 12. You're right.
Just thought I'd check.
Thanks. Good to check. Good to check. These aren't the only rules that are relevant to healthcare providers that have been published since the end of March. There are 2 privacy-related rules. One is the HIPAA privacy rule regarding reproductive health care. The other is the Federal Trade Commission's health breach notification rule. Both of those are going to be addressed in PYA's June 19th HIPAA update webinar. There are also an additional Medicaid enrollment rule that was published at the end of March. And then last week, we got the Dreamers rule regarding DACA recipients enrollment in different Medicaid and qualified health plans. We will not be addressing those 2 rules either today, but just to make you aware of them. Why so many rules? Well, we are in the rule season, as we call it, because this is the time period during which CMS publishes its federal fiscal year Medicare payment rules. There are 5, and they will go through the comment period, and we'll have the final rules published sometime this summer to become effective on October 1st, the beginning of the federal fiscal year. In June or July, we will see the proposed calendar year Medicare payment rules. There are 4 of those. The one we, of course, get all excited about, OPPS and Medicare Physician Fee Schedule. But why the additional final rules being published with such haste? That is the result of the Congressional Review Act. This is a statute that empowers Congress at any time to overrule any new federal regulation by passing a disapproval resolution by a simple majority vote. They have to take that action, however, within 60 legislative days of the final rules publication in the Federal Register. So when you have a change in Congress or a change in the administration, there is always the opportunity for the new folks to reach back and grab rules passed by the old folks that they don't like. And in fact, we look back in 2017 when we had a change from the Obama administration to the Trump administration, Congress stepped in and struck down 15 Obama era rules going back to May of 2016. Now, of course, between May and January are more than 60 days, but because the legislative session was so short in 2016, they were able to reach back and get rules into May of 2016. So not surprisingly, the Biden administration is trying to beat that deadline. It's not truly a deadline because we don't know how long the legislative calendar will extend, but they're trying to get as many of these rules published in the spring as possible to avoid the effect of CRA. That isn't to mean the next administration or any administration could not change rules that they don't like, but they'll have to go through the full rulemaking process of proposed rules, final rules, and the like. But they can't use the shortcut CRA approach after that 60 legislative days. Healthcare is not alone in the rush of rules. We've seen the Biden administration publish rules on fair housing, Title IX, gun safety, vehicle emission standards, drinking water standards, and the like. It's just we're obviously focused on those that are going to directly impact healthcare providers. So with no further ado, let's turn this over to Kathy to talk about proposed IPs.
All right, let's get started on the inpatient proposed rule. I think you're all familiar with the fact that whenever they publish the inpatient rule, they also include the long-term acute care rule. So we're going to do under item number 1, both IPPS and LTAC. Comments on this rule are not due until June 10th. June 10th is going to be right around the corner. Some of the other rules we're going to talk about, you have less time left to comment, but this one is of significant importance for you to think about your comments and to make sure you submit them as a provider or a hospital association. On the proposed rule, first thing I look at, because I'm a finance person, is I go to how much money are they going to give me? The proposed increase in the payment rate is about 2.6% over the current year, and that is assuming that you are a meaningful user of electronic health records and that you have submitted your quality data. The calculation, and we're going to go through this, or we have it for each of the rules, to get to that 2.6 was a 3% market basket, less 0.4 for productivity. Your current rate is about $6,500. It's going to go to close to $6,700 for your base rate that then is multiplied by or adjusted by your wage index and then adjusted by the case mix weight of the applicable DRG. The labor share, no change, 62% for those hospitals with a wage index less than 1, and those with a wage index greater than 1, you're staying at 67.6%. That 62% is statutory, cannot be changed other than by Congress, but the wage index for those hospitals greater than 1, the wage index percentage for those hospitals with a wage index greater than 1 is subject to change each year, but they did not change. Capital has been increased by about $13. That's a significant increase in your capital reimbursement, again, proposed. And your outlier threshold, again, a significant jump in the outlier threshold. The issue there is it will take a significant increase in the overall cost of care to hit that outlier threshold of $49,000 compared to the current $42,750. In the rule, we always see the payment tables that are published. We've included this in the slide deck, and you will get a copy of the slide deck later on today. But you can see table 1A provides the update for those hospitals with a wage index greater than 1, and table 1B is those with a wage index less than 1, but then also adjusting for that revised rate based upon whether or not you are a meaningful user of electronic health records. You could be you could meet both requirements, you could meet only one, or if you are not a meaningful user and you did not submit your quality. So all of that is outlined on this slide in case you need this for future information. From a DRG perspective, it's always good to look at what are they doing to shift around the weights and the groupings for the patients under the Medicare system. They will be using 2023 claims data and 2022 cost report data to adjust the weights for the DRGs. They are modifying the MSDRGs that are subject to the post-acute transfer policy. There will be an additional 5 DRGs subject to transfer, and 2 will no longer be subject. There are 10 new DRGs, and those are related to atrial appendage closure and cardiac ablation, spinal fusion, and also acute leukemia, retitling some DRGs predominantly associated with cardiac defibrillator implants, spinal fusions, and again, leukemia. These are being moved around. And then 3 DRGs are being deleted, all of which, again, apply to spinal fusion. So if you are doing predominantly, I'm going to stress the spinal fusion, treating acute leukemia, or the cardiac defibrillator implants, you need to look at how those DRGs are shifting and where this could have an impact on where your patients are grouping and the weights. Last year, we had a discussion of taking some of the social determinants of health and making them a complication, which would a complication of comorbidity, which would increase the weight of the DRG to which they were assigned. We have a similar adjustment being proposed this year related to housing instability or housing inadequacy. I've given you on the slide the applicable ICD-10 codes that would be considered, that if these are coded on the claim, the level of the DRG would move from a non-CC to a CC, increasing the weight. And so it is important that this information is tracked within your organization and coded on the claim, and coded in one of the positions that would be captured in the claims process.
Yeah, Kathy, it's interesting that CMS is making this decision based on its continued data analytics of claims that include these codes and determining, yes, these are more expensive patients to treat, which is not surprising, people that have housing instability or homelessness. But again, it's a very small number of historical claims that they're basing this on.
Because so many do not code this.
So many do not, but appreciate now that we have the hospital IQR measure for completing SDOH assessments, that's now giving hospitals the data that they can use to now code that to a Z code and include it in the claims data. And again, as we see more usage of the Z codes, there's going to be more opportunities for CMS to say, you're right, it's more expensive if we have people that have social isolation or people that have utility issues or whatever the different SDOH Z code categories are. So this is an opportunity to make use of that data you're collecting through that IQR requirement to help improve your reimbursement long term.
Absolutely. For a number of DRGs, excuse me, and even some of the simpler DRGs like pneumonia, it is a significant increase in the weight and therefore increasing your reimbursement. Mm-hmm. Forgive me, the cold just kicked in again. On the NTAP payments, the new technology add-on payments, they are continuing to cover 24 technologies that were previous in place. They are still considered new. They are assessing 26 applications. And that's the one thing I want to stress. Recognize that there will be pages and pages and pages of comments submitted on these 26 applications in terms of whether or not these should be considered new, what they are expected to do in terms of the care and treatment of the patient. So recognize that if this is something important to your organization, if there are particular new technologies that you are looking at using, this is worthy of comment. They are also suggesting or recommending that they change from April 1st to October 1, the time period to evaluate newness. Newness is essentially 2 to 3 years, and so that they would be pushing that a little bit. And then they are also looking at increasing from 65% to 75% the estimated costs of new technology for those services that are developed for gene therapy for treating sickle cell disease. This would begin in 2025, but it would then stay in place through their new period, which is 2 to 3 years. Again, it's not a set time period depending upon the technology. Disproportionate share, key issue for a lot of providers. We've included it in the slide deck, but all I can say is this seems to change dramatically every year from a proposed rule to a final rule. They are projecting a $560 million increase in the overall payments for disproportionate share and uncompensated care. But again, once they have more current data, last year we saw a significant switch where they had been projecting a huge decrease. We saw a slight decrease. We'll have to see what we're going to get with the new data this year. I think the one thing that could be of impact is whether or not we've got some of the Medicaid redeterminations that have now been captured in this data as it relates to the uncompensated care pool. So that could be a significant impact, again, varying by hospital and by state. Wage index, they are continuing, again, that low wage index policy that CMS put in place a few years ago that was supposed to run for about 5 years. They are continuing it, even though they were found by the courts to have implemented this incorrectly. But because CMS is appealing that decision, they continue to stick with it. Those hospitals with a wage index below the 25th percentile are going to have their wage index brought up to the 25th percentile, or half the distance between their wage index and the 25th percentile. But the payment for this essentially is going to be an adjustment to the standardized amount. So you have hospitals that win because they have their wage index brought up, but then you have hospitals that lose because there is less money in that standardized rate. The other item that I included in the wage index policy discussion relates to the consolidated, so the CBSAs. This is not as big of an issue for inpatient PPS impacting overall reimbursement. There is some, but when we hit a rehab and psych, it will be a significantly greater impact on reimbursement. But essentially, with the shifting of CBSAs, or areas moving from rural to urban and urban to rural, essentially what we're looking at is CMS for the inpatient system feels that the policy that they put in place a couple of years ago that would cap any adjustment to your wage index at 5%. It could not fluctuate greater than 5% from 1 year to the next in terms of a decrease. That will capture any significant changes on the inpatient PPS perspective. If it doesn't, it might be something worthy of comment in terms of should this be phased in any way as it relates to the inpatient system. But CMS does believe that for the most part, any major adjustments would be mitigated based upon the cap that they currently have in place. That cap applies to the other payment methodologies as well, but there are some other adjusters that are going to come into play when we modify the CBSAs. Okay, let's talk team. And we're not talking the application in which we talk and interact with the people that we work with, but we're going to be talking about transforming episode accountability model. I guess I want to say think back to the comprehensive joint replacement model, CJR. And this is a new CMMI. Let's try something different. It will be a mandatory 5-year payment model that will begin in January of 2026. And they are going to include 5 different procedures, both on the inpatient and the outpatient side. And if your market is selected, 25% of the CBSAs across the country will be selected, and this will exclude Maryland because of their payment methodology. 25% of the CBSAs across the country will be selected. It will be mandatory for you to participate as a hospital, and then you will have to participate for all of the procedures that are included in this model. We have listed both the DRGs and the HCPCS codes that are applicable on the outpatient side. So recognize inpatient and outpatient, mandatory CBSAs, mandatory procedures that are included. From the payment methodology, you're going to begin payment year 1. You essentially, it is an upside only risk, and then there are quality adjustments. Payments years 2 through 5. If you are a safety net hospital, a rural hospital, Medicare dependent, sole community, or an essential hospital, then you have 2-sided risk with limitations on your stop gain and a limitation on negative reconciliation. If you are not one of those hospitals described in track 2, you fall under track 3, which is basically 2-sided risk with quality adjustments, a 20% stop gain, stop loss, and quality adjustments limited at 10%. So this is bringing everyone together. It's bringing the hospital, the post-acute care providers, the physicians, the surgeons, others together to address the overall care of the patient. The quality measures that they're going to be looking at are the hospital-wide all-cause readmissions, patient safety and adverse events, and then for the joint replacements, it's going to be the total hip, total knee, arthroscopy, patient reported outcome-based performance measure. So these are all going to be measured. We do not know how much of the we don't know which hospitals, which CBSAs are going to be selected. All we know so far is that mandatory participation and that you're in, similar to what happened with CJR.
And kind of general description of the benchmarking, which, I mean, that's the good news, right? Since CJR, CMS has definitely refined and improved its benchmarking capacity. But that's always the game, is where does your benchmark hit on those procedures? Because that's going to determine whether you're a winner or a loser.
And essentially, you're going to find out in a couple of months whether or not you're in. And then it's effective January of 26, effective for 5 years. And you've got to get your physician buy-in and your surgeon buy-in, and you've got to begin working with those downstream providers. So it essentially gives you a year to get in place and to actually start taking action, because you want year 1 to be as effective as possible.
Yeah, and we're not withholding info.
26.
Yeah, we don't know when they're going to announce the CBSAs. They just sometimes, and we're hoping sooner.
Part of the final rule, but I don't know. I would urge you not to commit. Please don't include me, because I don't think they would kind of ignore that. But Marty, I guess it's time for polling question number 1.
Okay, Trevor, let's hear it.
Yes, the first question is, do you want your hospital to be selected for team? Yes, no, unsure, or I do not represent a PPS hospital. Remember, you must fill out the polling questions in order to receive CPE credit. You will have about 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to the presenters.
Unsure. That I agree. That is the best answer. For those 5% who said yes, I promise you we will not submit your names to CMS saying go for these. I guarantee you we won't do that, but we do appreciate your participation in that poll. Moving on, mentioned that the long-term acute care was included in the inpatient PPS rule. They're always combined. They are looking at a 2.8% increase in the payment rates for LTACs. Remember, we were 2.6 on the inpatient acute side. This is based upon a 3.2% market basket, less productivity and less outliers and other adjustments. Just like with the inpatient program, there is a reduction in your standardized payment amount if you do not submit your quality data. Labor share, significant increase in the labor share calculation for LTACs, going up from the current 68.5% to 72.8%. That means more of your payment rate is going to be adjusted by labor. So if you are in an area with a wage index greater than 1, you're going to get significantly higher reimbursement, whereas if you're in a market with a wage index less than 1, your reimbursement is going down. Look at the jump in the cost outlier threshold. Will this hold? This becomes, I think, a major concern for the LTACs because what we're looking at is a requirement that their outliers meet a certain percentage of their overall payments. It is set to be 7.975%. So in order to achieve that percentage, they have to increase the outlier threshold by $30,000. Very important if you operate in LTAC that you look at the impact of this on your organization, because it's going to be much harder to qualify as an outlier and to get that added reimbursement once you hit that threshold. So something that I think is important to do your evaluation on, and then secondly, to comment. Marty, were you about to say something?
Yeah, I'm about to ask you questions, Kathy. Is that there's really no reason to comment on the percentage because that's statutory.
Not on the percentage, but it's the issue of CMS can say we're concerned about the impact and therefore we're going to back off a little bit. I mean, there has always been a slight fluctuation on this. Last year they proposed a huge increase. They didn't do it.
And part of that's because the numbers changed, so they include Q4 data in the final.
Exactly. So it's a concern, but this could be a big hit for a lot of LTACs. And if you're an acute care hospital that is trying to transfer, and you've got concerns with LTACs in terms of overall payment, it might make transfers even more difficult. So just something to think about moving forward. If you follow the Federal Register, okay, I mentioned before, we do have the tables that are out there. This is the actual payment rates for the standardized rate, as well as your reduction if you do not submit your quality data. But following the rule, it goes from IPPS payment to LTAC payment, and then it jumps back to let's talk about some other things. So that's kind of the format we're following in this presentation. There was discussion of both hospital and critical access hospital conditions of participation. They are updating the infection prevention and control and antibiotic stewardship program, COP, to require weekly electronic reporting to CDC on certain respiratory illnesses. That would be COVID-19, the influenza, and RSV. If there is a public health emergency, then the reporting could be more frequent and additional conditions. You would be reporting confirmed infections amongst hospitalized patients, your bed census and capacity, as well as certain limited patient demographics. This would be effective in October of this year. So recognize this is increased reporting on hospitals and critical access hospitals. Again, something that I think you need to look at, moving this to a weekly electronic reporting.
Hey, Kathy, we can't leave the topic of critical access hospital COPS without noting that we are still waiting for the interpretive guidelines regarding the conditions of participation on infection prevention and control, as well as QAPI, quality assurance, performance improvement. Those changes to COPS were effective about 2020, right, during the pandemic,
Right.
but we're still waiting for interpretive guidelines to ensure we can clear survey. So our eye is still on that moving forward. The hospital COPS were, I mean, the changes to the hospital COPS, those interpretive guidelines came out last year, and we thought we'd soon thereafter see the CAW ones, but we have not yet seen them.
And what I think is important is, again, look at this, look at the requirement for weekly reporting. Do you feel that weekly reporting is appropriate? And look at administrative burden, comment as you feel appropriate. Inpatient quality reporting, they are looking at 7 new measures. We've given you those new measures on the slide, as well as the reporting year. A lot of these tie to the ECQMs, and you need to look at what you're currently reporting and the difficulty perhaps of tracking additional information. But this is that inpatient quality reporting, that failure to comply with this does impact your base rate. Promoting interoperability. Again, they're creating 2 new measures. The current antimicrobial use and resistant surveillance measure is going to be broken into 2 new measures for reporting, basically the same information, but it's not merged together. They will have 2 new ECQMs for both hospitals and critical access hospitals that relate to hospital harm. They have proposed a modification to the global malnutrition composite score, and they are going to be modifying ECQM reporting by implementing a progressive increase in the number of ECQMs that both hospitals and CAWs are required to report. This will be an ongoing process where we're going to see over time a consistent increase on the items that you are going to be asked to report as a part of promoting interoperability. Paying for value. I can't believe I'm saying this, but for both the readmissions reduction program and the HAC program, the hospital acquired conditions, there are no proposed changes, no additional diagnoses, no changes to the calculation of readmission rates or the methodology for imposing penalties. However, for value-based purchasing, they are proposing some revisions to the HCAP survey that would be effective on or after, for discharges on or after January 1 of 2025. And they would be adding 3 new submeasures to the HCAPs related to care coordination, restfulness of the hospital environment. I didn't know that that actually worked. And then information about symptoms. I always thought the issue was you couldn't get any rest in a hospital, but now we're going to be clearly asking a question on that. It will be interesting to see if the old stories hold true.
Also, the old measures noise level, right? They've now changed it to restfulness.
Yes. Another issue wanted to comment on related to this proposed rule versus some things that are going on in Congress right now relate to a proposal for small independent hospitals paid under the inpatient prospective payment system to maintain a buffer stock, is the term that they used, of essential medicines. They are defining small as 100 or fewer beds, and independent means you're not part of a chain. They actually went on to define a chain, and a chain is at least 2 hospitals. So you are truly on your own, and you've got fewer than 100 beds.
Okay, wait, do they define that by 10 or by management agreement?
That's true. And so essentially they are going to be giving you some additional money if you maintain a 6-month buffer stock of medicines that they consider essential. Meanwhile, in the Senate, they are looking at legislation that would give additional incentive payments to all hospitals who maintain a buffer stock of essential medications, and it relates to your contracting with the PBMs, your methodology for getting the drugs, and having a continuous agreement for drugs to be provided. So recognize we've got a proposed rule that would limit the types of providers that could get this additional payment. But when we're looking at the legislation in Congress, it would be much broader in terms of who would actually qualify for added payments under this program. That's it on inpatient. Comment. Oh, no, it's not. Couple of requests for information. First of all, and this has been an issue, a number of hospitals that I've talked to. How do you address unplanned visits, whether they're inpatient or outpatient, after the patient is discharged? Because as we start looking at some of the outpatient readmission measures, not impacting payment, but reported out, it is this question of when the patient then goes back for care. How can quality reporting better address these unplanned visits? Good area, I think, for comment. They are looking also at the impact of Medicare maternity care payments on other payers. So if what you have done is you have contracted with another payer, a commercial payer, for perhaps a multiple of Medicare, the fact that Medicare does not really have very many maternity patients, how does this impact your reimbursement from those other payers? So interesting issue that they're asking about. I don't know that they're going to go out and say, well, we'll double your payment from Medicare because you don't have very much of it. But maybe just by pointing this out, it's insightful for providers who are contracting with commercial payers on a multiple of Medicare to say, except for maternity patients, okay, and to carve that out and to make a different payment methodology. And they are looking also at comments related to, they would like you to address the development of obese service standards for both hospitals, critical access hospitals, and interestingly enough, rural emergency hospitals, which having obese standards in RE8. Martie?
You can deliver babies in ERs. We do that out here in Kansas.
Exactly. But it's going to be interesting in terms of what those standards might say that could then impact the overall length of stay for the patient in the REH.
Oh yeah, absolutely. Have to exclude them from the 24-hour rule, right?
Right, exactly.
I don't remember which rule.
Yes, that's true. That's it for inpatient. Now make that.
That was more than 7 minutes, Kathy, but okay, see if you can make it up.
All right. Okay, thank you, Martie. On the inpatient rehab rule and all of the others that I'm going to talk about, comments are due on May 28th. So this is the day after, I believe, you're off for Memorial Day. So recognize, get those letters submitted in advance for all of these. On the inpatient rehab, again, we're looking at a 2.8% increase in the payment rate, 2.6 for inpatient acute. We are looking at a change in the conversion factor from the 18,541 to 18,872, about a $2,000 increase in the outlier threshold. Again, in this one, you see outliers are going to be about 3% of total payments, where it was 7.9 for the LTACs. Wage index, again, the labor share is going up, up slightly, not a significant increase. But those new CBSAs that I talked about, where a hospital could move from an urban to a rural area or rural to urban, recognize that for inpatient rehab facilities, there is a 14.9% add-on to the overall payment amount for inpatient rehab if you're in a rural area. Well, now if your area has become urban, you would lose that 14.9% add-on. The 5% drop in wage index isn't it's going to mitigate some of the wage index losses, but nothing mitigates that 14.9% add-on that comes about because you are a rural rehab facility. They are proposing a transition in your loss of that 14.9% add-on over 3 years. I urge you to take a look at this and include comments as to whether or not that is enough time, because essentially it would be this year, next year, and you don't have the 14.9. Do you need more time? Should there be a longer transition to phase out that rural add-on? That is a significant adjustment to most rural IRFs, and it's very important. Your critical access hospitals that have inpatient rehab beds, they need to look at this as well because they're paid under the IRF PPS. Other issues, no changes to the quality measures for the IRF quality reporting program. The patient assessment instrument, they are looking at making a few changes there. You're going to see these on the other programs as well in terms of removing admission class, looking at new measures as it relates to the social determinants of health, and modifying the transportation measure to collect it only at admission, to limit the look back period, and to modify the responses to make it easier for the patient as you address transportation. They are also wanting to know, they have an RFI related to developing an IRF star rating system on Care Compare. What measures should be included, and would consumers use this to identify differences in quality, so that if you are an inpatient rehab facility, you might want to comment on that RFI as well. How was that, Marty? Skilled nursing. This is the next one, again, comments due on May 28th. 4.1% increase in the payment rate proposed for skilled nursing facilities. Significant jump in the time period used for the market basket for SNFs. That is the main reason for the huge adjustment. They jumped from 2018 to 2022 in terms of the actual market basket that they're using to measure changes in cost.
Kathy,
yeah.
am I right that SNF is the only PPS that affords an adjustment if CMS previously messed up its market basket forecast?
Correct. That is correct.
So that's why it gets a bigger raise.
Right. You can see on this that it says plus 1.7 percentage points related to a market basket forecast error. The other programs do not have that option for the positive adjustment. There can be a negative adjustment, but not a positive adjustment. So, there are some revisions under the SNF program that address the code mapping within the patient assignment system. Essentially, using the PDPM ICD-10 code mapping, that's how you get a patient into a category. They are changing some of the directions in terms of where the various codes go and the significance of the codes, but they are also asking for how should we perhaps modify the non-therapy ancillary component of the PDPM. So these ancillary services that are not therapy related, how should they address future payments for the SNF program? Again, as with inpatient rehab, they are modifying the patient assessment instrument to include social determinants of health, essentially the same ones that I had mentioned previously. This would be effective for admissions beginning on or after October of this year. And effective with fiscal year 2027, quality reporting period, the SNFs would be required to participate in data validation, which is not something that they are required to do. Other proposals related to SNF the SNF program, value-based purchasing, they would essentially looking at a revision to some regulatory language to address within the program how they select measures, how they remove measures, etc. Also, a big issue that has been raised as a part of this proposed rule and is getting a lot of attention relates to Nursing Home Enforcement Authority of CMS. Currently, CMS can impose penalties, civil monetary penalties on skilled nursing facilities and nursing homes with quality and safety deficiencies, but it only relates to non-compliance. It doesn't relate to the overall level of quality and the level of safety. They can only look at you are non-compliant, but it is the degree that is added within this particular rule. They would also allow the CMS to apply penalties, increase the penalties on a per instance basis and per day, both per instance and per day. Right now, they can only assess penalties on either a per day or a per instance basis, not both. So this could have a significant impact on underperforming skilled nursing facilities moving forward. Inpatient psych. Many of the same issues that we have commented on related to rehab and skilled nursing, excuse me, we're looking at a 2.6% proposed increase in the rates. The most significant change in the rates as it relates to inpatient psych tied to the payment for electroconvulsive shock treatment. They are proposing a change in the payment rate for ECT from the current $386 to $660. So that is a significant adjustment for a single service. The payment rate, it is, basically it's a slight drop. Outlier threshold, slight increase, but it is that ECT payment that is of concern. The labor share, slight increase in the labor share, increasing your reimbursement if you are greater than 1. And again, that 3-year add-on, that 3-year transition for the rural add-on. For inpatient psych, the add-on for rural providers is 17.1%. It was 14.9 for rehab. Inpatient psych is 17.1. Again, look at this in terms of, is a 3-year phase-in appropriate, or should it be a 5-year, 4-year, whatever it might be? But look at the overall impact of this on your hospital. They are looking at adding a new quality measure, a 30-day all-cause risk standardized ED visit following an inpatient psychiatric facility discharge. This would be reported beginning in calendar year 2025 with an adjustment to your payment rates in 2027. They are also proposing to move from annual to quarterly patient level reporting. Take a look at that as it impacts your overall administrative burden within your organization. And they are beginning to address an issue that was raised in the CAA of 2023 related to the development of a standardized inpatient psychiatric facility patient assessment instrument. This would be effective for discharges beginning in fiscal year 2028, and they are asking for input on the IRF-PI, what data elements should be included, administrative burden, and like that. I urge you again to comment on that particular provision. Other issues included in the inpatient psych rule relate to the filing of the all-inclusive cost report. Psychiatric facilities have the ability to do this. There are a number of facilities who have been filing all-inclusive cost reports, but they are now clarifying that beginning October 1 of 2024, unless you are a government-owned facility or an IHS hospital, someone who does not have a charge structure, you cannot file an all-inclusive cost report, nor will they allow you to convert to a system where you have no charge structure and would want to then file under an all-inclusive rate methodology. This is only going to be government-owned facilities and IHS. Finally, on the inpatient psych facility, they are asking for comments on how to revise the adjustments under this inpatient psych program. Should we be adding something like disproportionate share? What do we do about rural status? Do we keep that 17.1% adjustment? What about teaching? This was also a requirement of the Consolidated Appropriations Act of 2023 and something that we need to take a look at, again, worthy of comment. Last but not least is hospice. Very quickly, again, comments due on May 28th. 2.6% increase in the payment rate being proposed. The cap payment for the patients, this is your aggregate cap, would go from $33,494 to $34,364, just a slight increase. They are looking for comments on how they could create a separate payment methodology for high intensity palliative care services. So your patient is in hospice, but they are still getting radiation for palliative care. How should this be addressed? Because it's high cost, how should it be paid for under the hospice program? Quality perspective, they are adding additional measures. They are proposing to adopt the Hospice Outcomes and Patient Evaluation, or HOPE, patient level data collection tool beginning for 2025. Again, proposing some revisions to the patient satisfaction survey, and they are looking at should we be incorporating SDOH, social determinants of health, into the hospice payment adjusters. So something, again, to look at. With that, Marty, we can do our polling question and then I can turn it over to you.
Our second polling question is, does your organization plan to comment on the proposed payment rules? Yes, but IPPS only. Yes, all of them. Only some of the rules. None of the rules, or I don't know. Remember, you must fill out the polling questions in order to receive CPE credit. You will have about 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Okay, I don't know. Good. I think that's good if you, but I do urge comments. It's very important that someone within your organization comment, and don't rely on associations if you have specific issues, because they have to play the middle. Marty.
Well, let's shift gears from proposed rules, on which Kathy wants you to comment, to final rules, which you previously had an opportunity to comment on. Many of these new final rules had been proposed in late 2022, early 2023. And as we discussed at the beginning of our presentation today, it's a rush to the finish line by the Biden administration to have as many of these finalized to prevent the impact of CRA in the future, if that should happen. We're going to start with one that certainly got a lot of attention, wide and far, which are the minimum staffing standards for long-term care facilities. Although it's really been a focus on those staffing requirements, this rule also includes some enhancements to the facility assessment requirements for long-term care facilities. Presently, these facilities are required to conduct and then review annually a facility-wide assessment to determine the appropriate resources to care for those patients in their facility. There will be new requirements with regard to that assessment that become effective in August of this year, including using evidence-based methods when engaging in care planning for residents, using the facility assessment to assess each resident's specific needs and adjust as appropriate the resources within the facility. And then the process for developing the assessment, requiring the inclusion of a member of the governing body plus the medical director as active participants in the assessment process, soliciting and receiving input from leadership, management, nursing staff, and other staff as well as residents and family members. And as part of your assessment plan now, you will need to develop a staffing plan to maximize staff recruitment and retention. And certainly that will be very important as we move to the other key component of this rule, the staffing requirements. The administration stayed consistent with what it had proposed, despite having received thousands of comments with expressing concern about the impact this will have on the LTC industry as a whole. First of all, beginning with different start, and this will be consistent throughout these rules, we have different effective dates for urban facilities versus rural facilities. But the first requirement now is to have a registered nurse physically present and available to provide direct patient care services on a 24/7 basis. Emphasis on the available to provide direct patient care services. CMS is very clear that if it's a DON who's only present for administrative tasks, that does not satisfy the requirement. It has to be someone who can be at bedside when needed. This becomes effective in May of 2026 for urban facilities and a year later for rural facilities. Then we get through. That's just, it's the number of days from the effective date. It's a year from the effective date. I think
it's strange.
No, it's just the math, Kathy. Okay. I have no responsibility for it. But let's get to the issue with minimum number of hours of nursing care per resident day, and that measure is often referred to as HPRDs. The first requirement is one for 3.48 HPRDs, irrespective of staff type. So we don't have to have a certain number of hours by a certain type of staff. We just do this in the aggregate. That requirement becomes effective in 2026 for the urban facilities and 2027 for rural facilities. Where this really becomes problematic is the requirements to become effective in 2027, 2029, which is you have to have a little over half of HPRD from an RN and then 2.45 are HPRN from a nurse aide. So now we're getting specific on the type of nursing staff who can furnish these, that will be available for services for a specific period of time. Again, compliance is pushed out further, not till 2027 for our urban facilities, and then 2029, 2 years later, for rural facilities. The analyses we're seeing across the United States show that there is a very high percentage of LTCs who cannot meet this requirement at this point in time. There's just not enough registered nurses available that they have been able to hire to meet this requirement. So this is sort of a longer term issue that as this requirement becomes closer and closer, that will need to be addressed. As part of this rule, in conjunction with the publication of the rule, the administration announced $75 million to enhance nursing staffing within long-term care facilities. They've requested input on how that money should be spent and whether really $75 million is enough to address this type of issue within the industry. There is a provision that allows you to request a hardship exception, but it is a strenuous test. You have to be located in an area, a workforce unavailability area, meaning that you are at least 20% below the national average provider to population ratio for nursing workforce, or 20 miles or more from the next closest long-term care facility. In addition to meeting those objective tests, you also have to be able to demonstrate that you have made a financial commitment to staffing, looking at your total annual spend on staff, and are continuing to make good faith efforts to hire. You are not eligible for exemption if you meet one of the 3 requirements specified here on the slide. And if in fact you are granted the exemption, you're required to provide specific notice both to the residents as well as the general public that you are operating at less than required staffing levels. So there is our first rule regarding staffing levels. So let's do the polling question here.
The third polling question is, what is the most likely impact of the minimum staffing requirements? Several urban and rural facilities will close. Several rural facilities will close. Few facilities will close. The requirements will be reversed, or no opinion. Remember, you must fill out the polling questions in order to receive CPE credit. You will have about 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Well, certainly a mixed bag here, although most of you think there's going to be negative impact on facilities. I should have made mention of the fact that there are legal challenges that have been launched against these requirements. There's also been some conversation in Congress about addressing this through a legislative process, though nothing has actually been proposed yet at this point in time. So one of those, stay tuned. The story is never done with the publication of the final rule. We always have our day in court and our day up on the Hill to see what happens next. We're going to talk about two Medicaid rules that were recently published. Though these are requirements that are imposed by the federal government on state Medicaid agencies, they do have a direct trickle-down effect on providers. The first rule we're going to talk about is the Ensuring Access to Medicaid Services final rule. You'll hear this referred to as the Medicaid Access Rule in general terms. Again, these are requirements that are going to be imposed on state Medicaid agencies. The first concern home and community-based services. Here, there is a requirement to ensure that at least 80% of the reimbursement a HCBS provider receives is actually being spent on employee compensation. The idea here is to drive up compensation for HCBS workers, making it more attractive career opportunity for individuals, and we thus grow the workforce in that manner. The state is going to be required to post an average hourly rate paid for HCBS workers. They are going to be required to report on their waiting lists in their 1915C waiver programs, as well as service delivery timeliness for HCBS type of services. They are to impose a requirement that person-centered care plans for individuals receiving these services are reviewed and revised at least every 12 months for at least 90% of individuals who are continuously enrolled in the state's programs. There will be new standardized quality measures to be published by CMS, which the states will be required to report. And finally, the states are required to establish a grievance process if they do not currently have one for fee-for-service HCBS beneficiaries to submit complaints. The good news here, it's relative whether this is good news or bad news, is most of these requirements have pretty long lead times for implementation, between 3 and 6 years for most of the staffing requirements, but certainly directing state agencies to begin developing infrastructure so they are capable to monitor and report on a number of these activities. The second key component in the access rule concerned transparency requirements for state agencies. And this will be a welcome news for many providers, that states will now be required to publish and update their fee-for-service payment rates on a publicly available website. So we have easy access to those rates, as opposed to digging and digging and digging and often not finding the rate that's applicable in the Medicaid program. In addition to posing those rates, CMS is going to require states to compare their rates to Medicare rates for certain services, specifically primary care, OBGYN care, and outpatient mental health and substance use disorder services, so that we can see side by side the reimbursement available for Medicaid versus Medicare. Hopefully, I assume that's intended as an incentive to increase state rates in those particular areas. CMS is also requiring state Medicaid agencies to engage in certain processes to address critical incidents, as well as creating an electronic incident management system. So those are better tracked. You can monitor how the state is ensuring protections for its Medicaid beneficiaries. And finally, some new, I guess, administrative requirements, really transitioning the traditional medical care advisory committees into a dual framework now with Medicaid advisory committees and beneficiary advisory committees. This is actually the requirement with the shortest lead time that this is to be implemented within the next year. Okay, so we have the Medicaid access rule. Let's talk now about what's referred to as the Medicaid managed care rule. And this was a long-awaited rule to see how aggressive CMS was going to be in its regulation of state relationships with their MCOs. And a number of really critical provisions here going forward. Again, really varied lead time in terms of the effective date for many of these provisions. The first concern, network adequacy. So what requirements does the state have to impose in its contract with MCOs to ensure an adequate network of providers to protect access to care for Medicaid beneficiaries? And that is primarily focused on establishing appointment wait times. So an MCO will have to be able to demonstrate that it can provide a new patient appointment within 15 business days for routine primary care as well as OBGYN services, and then only 10 business days for outpatient mental health and substance use disorder. So the MCO is going to have to be able to demonstrate sufficient number of providers who are part of our network for Medicaid beneficiaries throughout the state to meet those appointment wait times. To ensure compliance with that, states are required to do secret shopper surveys to validate MCO compliance with these standard wait times, as well as the accuracy of provider directories. One cannot generate one's network simply by listing names in a directory. These secret shoppers will actually call up and say, are you in fact a provider that's contracted with this particular MCO? And they'll validate network adequacy through that methodology. Again, we're going to have a requirement that this idea of comparing to Medicare rates for accountability purposes, that state agencies will be required to have provisions in their contracts with MCOs, requiring those MCOs to complete annual payment analysis, comparing their rates to Medicare payment rates. There's some transparency requirements there. And then implement a remedy plan for any MCO that does not meet required access standards. So getting much more serious at the CMS level of requiring states to hold MCOs accountable, being more aggressive in that regard here. There are changes to the Medicare and CHIP quality rating system, so that we can have some standardization in both terms of measures and methodology of how states are requiring their MCOs to report on quality measures, so that we can do some true apples to apples comparison across states, across MCOs. And then similarly, we have standardization of the criteria used for calculating medical loss ratios, plus the reporting requirements associated around MLRs for our MCOs, again, so we can compare apples to apples of how much of the premium dollar is being spent on healthcare services and quality assurance versus administrative overhead and profit. So we have a fair comparison, similar to what we see in the Medicare Advantage program, bringing that sort of standardization into the Medicaid MCOs. The Stop the Presses provision in the Medicaid managed care rule concerns state-directed payments. And I'm about to completely nerd out on you because SDP's probably one of the most confusing aspect of federal healthcare reimbursement overall. That's kind of a broad statement, isn't it, Kathy? But every time I go into this rabbit hole, I'm not ever sure if I'm going to come back out. But state-directed payments are a way that a state agency, even though they've turned over their Medicaid program to be administration of MCO or parts of their Medicaid program to be administered by MCOs, they still want to get their hands dirty and direct payments to certain types of providers. The idea, commonly you'll see this around certain hospital rates You'll see it around providers that practice in academic medical centers. So they're trying to say, MCO, you need to pay this additional payment to these certain types of provider above your standard Medicaid rates. And we're going to make dollars available to you, MCO, to make sure that happens. But they're going to be earmarked dollars for that purpose. The good news was that in the final rule, CMS said that those rates can go as high as average commercial rates. So ACR, there was some concern that this was going to be as high as Medicare rates, but we got that higher rate that is available for state-directed payments. The big news here, though, was the requirement that if you have a state-directed payment that is funded by some sort of provider tax, to cover the non-federal share, we're now going to require that financing methodology fully comply with federal regulations. And in particular, CMS is focused here on hold harmless arrangements. So if you have a provider tax that's supporting the non-federal share of your Medicaid payments, so the roughly, on average, 40% that has to come out of the state coffers to pay Medicaid rates. Many states, most states, I think almost all states, have some form of provider tax to accomplish that. They take it from the hospitals. They use that money then as the federal matching funds. And in return, that allows you to increase the payments that you make to the hospitals that were assessed the tax. The concern here from CMS is guaranteeing that a hospital is at least going to see an increase in rates equal to the tax it paid, because typically the taxes are tied to bed size and the like. So you can have a facility that's really, really big, but has a very small Medicaid volume, and they're going to pay a high tax. They're obviously going to be concerned about getting that back in rates, given they have a low Medicaid population. And so we'll see hold harmless provisions actually built into the state legislation that authorizes these payments, or the new story is having those as separate agreements between the hospitals where the state is not directly involved. So it's sort of an off the books, hold the harmless provision. And CMS has been highly critical of those types of arrangements. And so they are saying going forward, we're only going to approve state plan amendments that provide for state directed payments funded by a provider assessment if that provider assessment meets all federal requirements, and that includes the hold harmless provisions. So probably sort of a tap the brakes on approval of no new plan amendments around state-directed payments and provider assessments. That, of course, raises the question, well, what do you do with everything that exists already? So at the same time that CMS published the Medicaid managed care rule, they published a notice of enforcement discretion where they said that we're basically going to work with you collaboratively through the beginning of 2028 to make necessary adjustments to your programs to bring them into compliance. We're not going to start, not going to put the hammer down starting immediately, but instead give you roughly 3.5 years so that we can bring all of these programs into compliance, get rid of the unnecessary, inappropriate hold harmless provisions. It's going to be an adventure, though, to say the very least. There are also other program integrity standards that have been adopted for state-directed payments of all types, not just those that are funded by provider taxes, but certainly this is going to kind of open up the Pandora box. It's very typical for hospital associations to be engaged with their members in advocating for legislation to promote these different types of payments. That's certainly all going to be in the mix now as we figure out how CMS is going to control these different costs. There's just a scathing General Accounting, the GAO, General Accounting Office report that came out in late of 2023, where they took the position that there were just billions of dollars that the feds were being required to pay out because of the matching requirements for these state taxes. And so this is at least some effort to control that growth in those programs. The final issue we want to touch on in the Medicaid managed care rule is the in lieu of services and settings, the ILOS rules, which allow MCOs to provide a service different than the traditional standard Medicaid benefit, so long as they can demonstrate that service is medically appropriate and cost effective. What we see here are now requirements from CMS that states build into their contracts appropriate safeguards to ensure eye loss doesn't become a way of payers avoiding appropriately paying providers for particular services. Lastly here, oops, I thought there was one more slide there, but again, like the Medicaid access rule, the Medicaid managed care rule has a variety of phase-in dates that will impact how those new requirements roll in. You already probably, shaking in your boots right now. What you see on the screen is the FTC non-compete clause. Wow, boy, did the phone start ringing off the hook when this thing was published, because we never thought they'd do it, is what I kept hearing providers say. We know they proposed this, but we never thought they'd actually finalize it. And they did just that. And this rule becomes effective very soon, on September 4. I think that's just right after or right before Labor Day. So it's going to be a long, hot summer, figuring out exactly how this new rule is going to impact providers. Again, this is a general rule. It's applicable across the board. It's not specific to healthcare providers, but it certainly is going to have a significant impact on healthcare providers. So what FTC has said is that a non-compete clause, which is both a prohibition on working for a particular employer or a penalty imposed on a worker for choosing to work for a particular employer post-discharge, such as liquidated damages or forfeiture of severance or buyout clauses, all of those things, they are now considered a anti-competitive conduct, and thus it is prohibited under the FTC Act. So now we know they're not enforceable. How is that rule going to be implemented? Well, for workers other than, quote, senior executives, and we'll come back to that, it is now an unfair method of competition to enter into such an agreement, attempt to enter into such an agreement, to enforce such an agreement, attempt to enforce such an agreement, or to represent to a worker that they are subject to a non-compete clause. First of all, let's define worker. It's not just employees. It's also independent contractors, externs, interns, volunteers, apprentices, and sole proprietors, excuse me. So all those folks, you can't require a non-compete as a condition of their working on your behalf. And this, again, effective September 4 of this year. For senior executives, we have a bit more leniency. The prohibition above does not apply to non-competes that were entered into prior to the effective date, September 4. Senior executive is defined as one who has the authority to make policy decisions for the entity, not just advise or exert influence, but policy-making decisions for the entity. Plus, they have an annual compensation of at least $151,164. That's a set federal rate. The FTC, in its commentary in the final rule, says that it believes most physicians will not qualify as senior executives, even those folks that serve in a capacity as a medical director for a certain department or serve as practice group leaders, because that is not a policy-making decision on behalf of the entity. It is only on behalf of the department or a subsidiary of the entity. So they do not expect that those physicians' non-competes will survive past September 4. The interesting question here, of course, is contract renewals. That if we have a contract with a senior executive that goes on for 3 years and it renews automatically or the like, is that going to sunset any non-compete that was in that prior agreement? Is that considered a new agreement being entered into after the effective date? Most likely, I expect FTC is going to say yes. There are obviously some exceptions to this rule. It does not impact non-competes that relate to the sale of a business. Meaning if you're the seller of the business, you can agree to a non-compete individually, but you cannot obligate any of your workers under a non-compete as part of the sale of a business. You still can prohibit a current worker from working for a competitor at the same time. These are all after the end of employment type of non-competes that are the focus here. You can still have confidentiality provisions. You can still have prohibitions on the misuse of trade secrets, other ways that you can prevent an individual from using knowledge they obtained in the course of your employment or access they had to trade secrets. using that in an non-competitive manner, after they leave your employment. Those are still enforceable. And probably the most interesting exception and broadest exception when it comes to healthcare is that the FTC Act itself, which is the statute under which the FTC was acting in creating this rule on non-competes, it is only applicable to organizations that carry on business for its own profit or for those of its members. Okay, so you'll hear this sort of tossed out that, well, this rule is not applicable to not-for-profits, so most healthcare hospital health systems aren't going to have to worry about it. However, be careful, because in a lot of instances, the entity that's employing the physicians, for example, is a for-profit entity that's a subsidiary of the not-for-profit organization. FTC, again, the final rule says, no, that for-profit entity is subject to this rule, regardless of the scope of the FTC Act. And they go broader. They talk about nonprofit organizations that behave like for-profit entities, and specific, like the money quote here is, merely claiming tax-exempt status and tax filings is not dispositive of the scope of the FTC rule. So if you are acting like you are for-profit, FTC may say that you are now subject to the prohibition on non-competes. Sort of the open question out there as well are entities that are part of or sponsored by state or local governments. Generally, that would fall under the state action doctrine, which if a behavior is engaged in by an entity on behalf of the state or at the direction of the state, that cannot be anti-competitive. And so there's still this question if you are a hospital district or a part of a university system or things like that, whether these rules are going to apply. Certainly, it's probably time to chat with the lawyers to figure out exactly how you're going to approach this going forward. Last but not least, fire up the copy machine because you've got some notice requirements that you're going to have to publish for your workers who are supposedly now under non-competes. The proposed rule had said you're going to have to legally modify those agreements. They said, yeah, we're not going to do that. Instead, the employer is now obligated to provide a worker who is subject to a non-compete presently a clear and conspicuous notice by the effective date, remember, by September 4, that the non-compete is no longer effective or enforceable, with the asterisk, obviously, for senior executives, that's not applicable. Very specific requirements that the particular notice that you provide has to have the worker's name on it, so you can't just do a generic notice posted on the cafeteria wall and call it good. You actually have to send them out to individual employees, and you can see the methods that are approved by CMS. Handy dandy, not CMS, I'm so shame on me. This is FTC, right, Kathy? I had to keep my federal agency straight. But you see there on the right-hand side of the screen, the proposed notice that FTC circulated as part of the final rule. So this gets to really interesting questions of like, when am I going to provide this notice? Well, that is obviously tied to the litigation that has now ensued over this final rule. The Chamber of Commerce, as well as other entities, are seeking injunctive relief. There are several lawsuits that have been filed in the state of Texas and federal district court. They are looking both to delay the effective date or just vacate the entire rule in its entirety. The central issue here is what's referred to as the major questions doctrine, that if an agency takes major action and makes major policy decisions, it must have clear congressional authorization to do so. And the question that gets really interesting, that's going to be the basis of challenging this, that the FTC just didn't have the authority under the FTC Act to take this particular type of action. They certainly have the authority to declare something a non-competitive activity, but they didn't have the authority to exercise that in such a way that would have such a broad impact across the economy as a whole. Well, the issue we have here is what happens in different jurisdictions, because this, of course, may have to work its way up to the Supreme Court. But if the courts in Texas decide, yes, there's an injunction, but the courts in Tennessee say, no, we're not going to grant injunctive relief, what happens? So will you have a nationwide injunction? Will you have an injunction that's restricted to certain jurisdictions? But all of this, with this all in the mix, right? When do you provide notice to your employees? There's no injunction in effect today, May 8th, 2024. No court has ruled yet on this, at least as of the time we started the webinar. May have happened since while we've been talking and talking and talking. But the question is, what are you going to do with litigation going forward? Do you provide the notice now, or do you wait till the very last minute on September 4th to see what's going to happen? That brings us to our next attendance question, please.
The next question is, do you believe the courts will prevent the FTC non-compete clause final rule from taking effect on September 4th? There will be a national injunction. It will vary by jurisdiction. The rule will be effective nationwide, or no opinion. Remember, you must fill out the polling questions in order to receive CPE credit. You will have about 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Kind of a mixed bag there on what's going to happen going forward. 17% of you are just ready to jump right in and send out those notices. Okay. See if we can get to the next slide. Thank you. Okay, 5 minutes, 3 rules. We can do it. The Department of Labor overtime pay final rule, again, broad application, but certainly impacts healthcare providers as well. What we have here is a change in the minimum annual salary to claim an individual is an exempt from overtime pay. So whether you're an exempt employee is tied to how much you make and whether you meet the duties test. And we're, as you see on the slide here, we are significantly stair-stepping up those minimum salary requirements. It's done in 2 phases for a reason. There's a immediate effective change July 1st of this year. That's using the formula that was adopted by the Trump administration 3 years ago. It's just simply doing the 3-year update for that formula to calculate that base. The second jump up in January of 2025 is a new formula introduced by the Biden administration. And so it's going to be much higher. It will then be adjusted going forward. The question here is, are we going to see litigation over that bigger high jump up? So pay attention here, but certainly this is at least the first part is very likely to go into effect. How are you going to prepare for your changes? Because healthcare organizations have a lot of employees that are within those bands of salary. Identify who those employees are, decide whether you're going to increase their salary to avoid making them non-exempt employees. And then how are you going to roll out these reclassifications, again, in these 2 steps going forward. Next up is the HRSA 340B administrative dispute resolution process. Again, the Biden administration changing the rules from what the Trump administration had approved. The Trump administration regulations really had a trial-like process, like the federal rules of evidence applied, federal rules of civil procedure. This is an alternative that is much more dispute resolution driven. It's the creation of an ADR panel that can handle claims filed by both covered entities and manufacturers. It is a specific process for filing that is defined in the rule, and how the HRSA, the Office of Pharmacy Affairs will provide additional guidance going forward as this ADR process is being stood up.
And I think also Martie addresses who needs to be on that panel.
Yes, exactly. Very, very specific in that regard. So this is great news from providers that are covered entities under 340B, a much more direct process, a less onerous, expensive process to deal with what you believe are inappropriate practices by manufacturers. Finally, last but definitely not least, is the OCR's non-discrimination healthcare programs activity rules. I'm simply going to whet your appetite because I am certain, Kathy, we're going to come back and revisit this in the fall with a full HCR webinar because there's some significant impacts here. Again, this is sort of, we're just seeing the change over change over change. So the Affordable Care Act, Section 1557, prohibits discrimination in health programs and activities that receive federal financial assistance. Initial implementing regulations from the Obama administration in 2020. Those are succeeded by the Trump administration's rules in 2016 originally, 2020. And then now they're being superseded by a 2024 rule. It's like watching a ping pong match, right? They had proposed a rule in July of 2022. They received a whole lot of comments. This new rule goes into effect on July 5th. It is important to note that this applies to all Medicare and Medicaid participating providers, MA plans, Part D plans, state agencies, Medicaid managed care plans, as well as those that are on the qualified on the exchange. So very broad in its reach. Key provisions. If you have 15 or more employees, you now have to have a Section 1557 coordinator. That's not a full FTE, but someone has to be the buck stops here. You have to implement policies and procedures that address both limited English proficiency as well as reasonable modifications for individuals with disabilities. So those are the two focuses on your policies and procedures. You have to include a grievance procedure if you have more than 15 employees. You have to have employee training on those policies and procedures, and you have to comply with new notice requirements, both the notice of non-discrimination as well as the availability of language assists and auxiliary aids. Also, in addition to those affirmative requirements, we now have provisions that redefine what constitutes discrimination, very more inclusive in terms of intersex traits, pregnancy and related conditions, sexual orientation, and gender identity. So again, broadening out who is protected under these rules. There is a kind of a rewrite on the religious freedom and consciousness rules that, and the prior rule, or the one that's effective through July 4th, it was a very broad exception. This is much more a limited exception, but there's a formal process that will be in place to claim your assurances. And then importantly, it extends the non-discrimination provisions to both telehealth services, how you provide telehealth must address disability, as well as limited English proficiency, but also reaches patient care decision support tools, or what we all call AI. If you are using AI in any capacity, it will now be required after the effective date, which we'll mention here in a minute, that you are taking reasonable action to identify any tool that is employing inputs or variables based on a prohibited class, and determine that in fact that AI is perpetuating discrimination by the manner in which it is processing data. And so you are then required to make reasonable efforts to mitigate the risk of discrimination from the utilization of an AI tool. The good news is that this rule has a very complex set of implementation dates. The only thing that's really effective in a very near term is having the coordinator, the 1557 coordinator position, which is within 180 days, as well as that notice of non-discrimination also has to go out within the 128 days. Otherwise, we're working within about a year to get these requirements in place. And again, it's time to get this on the radar screen. Don't let it sneak up on you within this next year because of policies and procedures and having training and providing notices and the like. There's a lot of work that's going to be bringing you into compliance. So we're going to wrap up then with the last attendance question. So Trevor, you can finish us up here.
The last polling question is, which rule worries you the most? Minimum staffing standards for LTC facilities, FTC prohibition on non-compete clauses, DOL overtime pay, Section 1557 final rule, or no opinion? Remember, you must fill out the polling questions in order to receive CPE credit. You will have about 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
The staffing standards, interesting, very at the top of the list. Okay, well that brings us to the end. Just a quick reminder of upcoming healthcare regulatory roundups. May 22nd, we'll do a MIPS refresher course, social determinants on June 5, and then as I referenced previously, June 19, healthcare privacy update, including those 2 new rules. Thank you for joining us. I apologize, we went 3 minutes over. It's all Kathy's fault, right? No. But thank you so much for joining us today. It's fine. I was interrupting Kathy. That's what delayed us.
Give us any questions, please.
Right. Please include questions. We'll get back with you on those.
Thanks to our presenters, Martie and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey for CPE credit. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings of every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, www.pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.